Okay, welcome everyone, Chloe. So today we're starting chapter 11 on substance abuse disorder. So I'm going to share my screen, and I think yep, here it is. Okay, and here we go. What is substance abuse? It's excessive use. What is tolerance? Biochemical changes in the body, both, um, both within our nervous system, our gastrointestinal system, you name it. Okay. Substance dependence, the physiological need for increasing amounts. You become dependent. And then withdrawal, these are the physical symptoms from the abstinence as a result from tolerance. So, some common examples of abuse of substances: nicotine, alcohol, barbiturates, tranks, amphetamines, heroin, ecstasy, and marijuana. Yes, even marijuana. Alcohol related. So, basically, all we're going to cover today is alcohol related disorders. And this is by far the worst one. I know that everyone thinks that opiate addictions are the worst. They create what's called motivational toxicity. And so, what does that mean? It means that we have certain motives to survive individually, and they are to eat, to drink, to sleep, to excrete waste, sex, as in sexual intercourse, temperature regulation, okay? The things that are necessary for our immediate survival. Now, someone who is addicted to opiates will sacrifice those in order to continue to use. So, our response to the specific drug is dependent on its addiction liability, meaning how addictive is it. So, going to alcohol related disorders, we say it's the worst for your body, essentially, because it has a global effect. It does terrible things to your brain, terrible things to your gut, terrible things overall. All right, so going back in time, looking at ancient cultures, we've seen excessive and frequent alcohol use. The Egyptians made the first beer in 3000 BCE. Italians made the first wine, and there were problems with alcohol use first observed in these cultures. The World Health Organization no longer recommends the term alcoholism, but refers to it instead as harmful use of alcohol. And this is important right here. Heavy episodic drinking is the consumption of six or more alcoholic drinks on at least one occasion, at least once per month. Looking at the prevalence, the comorbidity, the demographics of alcohol abuse and dependence. Alcohol abuse cuts across all age, educational, occupational, and socioeconomic boundaries. Lifetime prevalence for alcohol abuse in the United States is 13%. Again, enormous detrimental physical effects. It's linked to accidents, violent crime. It's more common in men, and more than 37% of alcohol abusers suffer from at least one coexisting mental disorder. At higher levels of alcohol consumption, it depresses the brain's functioning. At lower levels, it stimulates certain brain cells and activates the brain's pleasure areas. So, this is news you can use. Drinking, right? So as you drink, so this is the time in hours, your blood alcohol content goes up. And then when it peaks, it's about, if you look at the hangover severity from the time you start to the worst part of your hangover is going to be about 12 to 14 hours. What this means is that you hit this peak and then it drops. And as your buzz goes down from the blood alcohol content going down, your body begins to respond to metabolize it. Okay, And here's the hangover right here, the worst time, 12 to 14 hours. So if you start drinking at 8 p.m., your hangover is going to be the worst at between 8 and 10 in the morning following day. So, what are some things that it can do physically? Well, malnutrition, cirrhosis of the liver, stomach pains. It could lead to chronic fatigue, oversensitivity, depression, impaired reasoning, personality deterioration. All of these lead to psychosocial effects. Okay? All of these lead to these problems that you have, both psychologically within yourself and your ability to get along with others. Personality deterioration means that things that made you who you are, your agreeableness, your openness, or your emotional stability, whatever these levels are, extroversion, they all start to deteriorate and you become essentially someone you're not. Psychoses associated with severe alcohol abuse, alcohol withdrawal delirium. People will experience disorientation, hallucinations. And this may last 3 to 6 days. Alcohol amnestic disorder, memory loss, disorientation. And if it's untreated, it can lead to irreversible brain damage. So, what causes people to become alcohol abusers or, whatever? The biological. So first, we're going to discuss the neurobiological aspects of addiction, and this stands for, on the next slide, the mesocortical limbic pathway. I'll explain what that means in a second. And basically, what it's saying is that we experience joy from it. Okay, and then there's genetic vulnerability, so things that we've inherited. Alcohol risk personality. You've heard of like people having addictive personalities, right? It means they're more prone to having they're more prone to developing addictions. And then again, our learning. So when we're exposed to it, if our caregivers drink it, if our friends, family, other family members, our culture, and then our experiences with it. If we have good experiences, we're more likely to develop an issue. So here's what happens essentially. Alcohol stimulates the VTA, which then stimulates the nucleus accumbens, which then feeds the prefrontal cortex, which is where our thinking is. And this pathway is what we call the pleasure pathway to release dopamine, is the idea. So anytime you're talking about like any reward, any kind of even novelty, even when we're like, oh, that's new, that's cool. When we experience those kind of events, it's the VTA to the nucleus accumbens to the prefrontal cortex. Psychosocial causes, failures in parental guidance. What does that mean? It means that you're a teen, you're sneaking out, they're not like taking care of you as far as like, hey, no, you can't. For example, I remember one summer I was younger, obviously, and it was before I was of legal age. I went to a graduation party. I think I was a sophomore or junior, and there was a bunch of beer and a bunch of coolers, and the I was friends with the brother, and his older brother graduated. So I went to this party, hanging out with my friend, and we snuck some beers. And my oldest brother found out, and he told my parents. He actually went to the party too. I didn't know he was going to be there, and so I drank, and I definitely was, I guess buzzed or whatever. And he told my parents, and they grounded me for the rest of the summer. That's what happened to me. All right, psychological vulnerabilities. People who are experiencing depression, people who have, it's also correlated or comorbid with antisocial personality disorder, certain environmental stressors, right? Job, maybe, relationship down here, certain just stress, uh, financial. Well, it reduces our tensions, right? And so it's reinforced every time we do it, we feel better. And so we do it again. The expectations of social success, so those sorts of pressures, whether they be academic, relationship based, financially based, whatever, social status. And then lastly, marital or relationship crisis. So marital discord, you have a bad marriage or a breakup of some kind. Even our religion has an impact. Uh, your text speaks about speaks of the Muslim religion, the Mormon religion, where alcohol consumption is forbidden. So the rates of alcoholism, which I guess we don't call anymore, but the rates of substance abuse regarding alcohol are significantly low. Um, Geographic location, it's very high in Europe, in certain parts of Europe. And then the cultural tradition of aggression. Um, you see that some aggression, um, you see aggression higher in some areas than you do in others. So like Australia is high in aggression. Um, some Celtic or Gaelic cultures, Irish, Scottish. So the use of medications in treating alcohol abuse and dependency, we could use antabuse, right? So this means that they have a very, very negative reaction to drinking alcohol, violent vomiting, naltrexone, which is supposed to reduce the craving for it, and then Valium, which is supposed to be used for the initial focus, or sorry, used for detoxifying to lower the side effects of the acute withdrawal, to calm down, you know. We could use group therapy where the person is confronted with a group of people and they're forced to address it and admit that they have a problem. What's that show? Intervention? I think it's intervention. Then there's environmental intervention where they have essentially your community will develop halfway houses. There's behavioral and cognitive behavioral therapy. So the behavioral is where you have, you know, you're saying that you do this, um, you associate with bad uh, consequences. So that'd be the aversive conditioning, and then the cognitive behavioral therapy where you're trying to change the way people think and act about in regard to it. So um, you you want to have them learn skills to avoid it, to deal with it, um, and to develop those self control skills. So the controlled drinking rather than just total abstinence. 15% of subjects were successful with controlled drinking, meaning I can have it now, but I can't, you know, any more than these specific scenarios, like on maybe a drink on the holidays or something. But controlled drinking is more likely to be successful with people with less severe alcohol problems. And also we have Alcoholics Anonymous. The success rates of alcoholism treatments, there was something called Project Match. And then also we have a motivational enhancement therapy, which is a 12-step program. And CBT, why am I drawing a blank? Oh, cognitive behavioral therapy, right. Um, and then we have relapse prevention programs. So going to the match, Project Match, the idea here is that they match patients to particular treatments. So you have this problem with drinking surrounding because of something related to a stress or something related to a marital discord or something related to whatever it is, a biological predisposition. So they try to match the treatment with what they think the cause is. And what they found was it wasn't really important in that they had similar success rates through all sorts of treatment. Motivational interviewing, where the clinician guides the patient through a collaborative conversation in which the patient articulates the pros and cons of drinking and ultimately makes a decision about whether he or she is motivated to change. So the idea here is that, yeah, you're sitting down with a clinician and saying, all right, tell us what the good things about it are. Tell us what the bad things are about it. Now you weighed the cost, you weighed the benefits. Now, do you think that you're motivated to change those things? Relapse prevention. One of the greatest problems in the treatment of addictive disorders is maintaining abstinence or self-control. behaviors underlying relapse are seen as indulgent behaviors based on a person's learning history. There's something called the abstinence violation effect, where they have a slip up, just one minor transgression, and now it's seen by the person who's trying to quit as a drastic significance, as having a drastic significance, and then as a result, they're like, well, I messed up last night, I guess it's over, and they just go right back to it. Okay, so that's the abstinence violation effect. In relapse prevention treatment, the clients are taught to recognize the apparently irrelevant decisions that serve as early warning signals of the possibility of relapse. And then lastly, we're training, clients are training people to not become discouraged, to not be a victim of the abstinence violation effect. You're going to slip up maybe, okay, but don't quit. You know, a lot of people slip up. So drug abuse and dependence. So psychoactive drugs are most commonly associated with abuse and dependence. Narcotics, sedatives, stimulants, anti-anxiety drugs, pain medications, hallucinogens. An estimated 21.6 million people in the United States ages 12 and older report having used at least one illicit drug during the past year. Drug abuse and dependence are most common during adolescence and young adulthood. In an employment study, what they did is they asked people seeking employment to fill out a survey or whatever. 19% of those who were 18 years of age or younger said that they had used it. 10.3% for those 18 to 25. 7, 26 to 34, 7. So you can see it decreasing as we age of having used illicit drugs in the past year. So our behavior patterns depend on the type, the amount, and the duration of drug use. It depends on the physiological and psychological makeup of the individual, and it depends on the social setting in which the drug experience occurs. So what is this saying? It's saying, where we choose, when we choose, and how we choose to use an illicit drug, excuse me, depends on the drug we take, how much of the drug we've taken, and how long we've used it. It depends also on our body's physical makeup and our body's metabolism rates. It also depends on our experiences. It depends on, was it a good experience when we were at that party and we tried cocaine for the first time, or heroin for the first time, or a beer for the first time? So it depends on the setting as well, and also the reasons for taking.